Yep, we're good. Well, it's good to be back. As Dr. Driscoll said, I haven't given this talk for a little while, and a couple of my colleagues have been involved in this group as well. I noticed a couple of people as I walked in that I recognized, and it's good to see you all again. I was asked to talk a little bit about the orthopedic management of some of the limb discrepancies that we see with the vascular malformation group, and they involve primarily length differences, but there's a whole bunch of other stuff that accompanies this. And so what I'll talk about today is some of the surgical management of some of the limb discrepancies and the abnormalities that we see. This is an idea, this gives you an idea of what we deal with. The limb overgrowth is what I'm going to primarily talk about, but there's also arthritis that can develop in joints, what we call contractures or stiffness of a joint. Some of the vascular malformations actually involve muscle, and these are interesting because they cause pain whenever the muscle moves and can result in a fairly debilitating problem. If you can't move a muscle, can't use a muscle, and every time you try to do it, it hurts, it can result in significant difficulty, even if everything else works. And then there's a rare group of patients who have actual vascular malformations within their bone. And this can cause difficulties as well, not only with pain, but with weakening of the bone, leading to fractures, and difficulty with treatment, because when the vascular malformation involves the bone and you do something to the bone, like break it or try to put a drill in it to fix it, it bleeds. And it doesn't just stop, it's not something you can compress, and it makes our life difficult. It makes our patients' lives even more difficult. There's a huge spectrum of these vascular malformations, as you've already heard about. These are 3 patients that I've seen over the course of my career. And some of them are relatively minor in terms of their outward manifestations. Some are unusual, and some are absolutely defined in terms of how to deal with. What is interesting is that it's very unusual to see 2 patients who are identical with these vascular malformations. Everybody's a little bit different, and it does introduce some problems when we talk about trying to standardize treatments. But the primary reason I'm asked to see folks with these things are that they cause differences in length. And the problem is almost always too much growth in the limb that's affected by the vascular malformation. It turns out that the increased blood flow to the limb that is involved is a bit like watering your grass. It causes the limb to grow. And we know that just about any condition that increases blood flow to a limb causes it to grow more in a child. In adults, this doesn't happen because they're not growing in the first place. But in children, anything you do will cause the limb to grow more. The biggest bunch of this data comes from fracture patients. Whenever a child breaks their bone, the body responds by trying to heal the bone, and to do that, it revascularizes the leg and supplies the broken leg with more blood than the unbroken leg. And for a period of about 6 months or so after a fracture, that increased blood supply is there and causes the broken leg to grow longer than the unbroken leg in children. This is something we've known about for long periods of time. There are other conditions such as rheumatoid arthritis in children, which causes increased blood flow to the joint that's involved. And those bones always get bigger and longer than the uninvolved side in children. And the vascular malformation patients have the same problem. They have increased blood flow to their limb, it's warm, it sweats more, and it grows longer because the growth plates, which are these little black lines in the bone, which is where the long bones grow, get more water on the grass than the rest of the body does, and they disproportionately grow. So your leg grows in 4 different places if you're a child. Right up here at the top, here near the knee, just below the knee, and down at the ankle. The center of the bone doesn't grow. It grows in girth. It's like a tree trunk. It gets bigger. but the length comes from the two ends of the bone growing away from the center. And if a vascular malformation is involved in the leg grows more. It doesn't have to be very much. This was a child who was only 3 and had a very tiny leg length difference, but had a vascular malformation. And you can see the girth is bigger on this side. It's a bigger limb. That's why it shows up as being kind of white. And on the MRI scan, we can see the vascular malformation out here in the fatty layer under the skin, and even in the bone. And that causes these growth problems, and that continues as long as the child keeps growing, 16 years or so. So this is kind of what we see. These vascular malformations are small when the child's born, might only be 1/8 of an inch or 1/4 of an inch, but the leg length difference gets bigger as the child gets older. And the proportions tend to stay about the same. So if a baby has one leg that's 5% longer than the other leg, you can pretty much guarantee that by the time they're adult, their longer leg is going to be 5% longer than their shorter leg. But 5% of that much is little, 5% of this much is a lot. So it looks like the leg length difference gets bigger, but in fact, the proportions remain pretty much the same. So you can look at 3-year-olds who are about half as tall as adults and guess pretty well how big the difference is going to be when they're done growing. It's about twice as much as it is when they're 3. And that works, in vascular malformations, that works pretty well. It obviously doesn't change after maturity, and in most of these kids, it's usually less than a 2-inch difference between their legs. The arms, which are shorter, usually have less arm length differences than the legs do because they're longer. Does everyone get a leg length difference? No, in fact, probably the majority of the patients do not have unequal leg lengths, but about 20%, we treat about 20% of the kids that have the vascular malformations for a leg length difference. And it can be as much as a couple inches, 3 inches, or as little as just a few millimeters. This is how we measure leg lengths. We have an x-ray that, this is the old way of doing it, and a standard x-ray, unfortunately, is like a light bulb, and the little game you play with the projector in your hands, it magnifies the image. So a standard x-ray makes the leg length difference look bigger, makes everything look bigger because it magnifies it. So you have to use something like the old Xerox machine that had the moving light that sort of moved from one end to the other. It just takes a scan of the part that it's trying to reproduce, and that's what we use. We have these devices mounted horizontally and vertically, and some of you may have gotten to stand or lie on them and have your x-rays taken over the years. You get something like this, which is a non-magnified view of the limb, and so we can measure right off the x-ray exactly how long the legs are. In this 9-year-old child, the leg length difference was 1.8 centimeters, which is just a little over ½ an inch. And the child's longer leg was the one involved by the vascular malformation. It turns out humans tolerate leg length differences pretty well. I've always said that people have been around a lot longer than level floors have. We weren't really designed to deal with perfectly flat floors. And the flat floors are a recent innovation in human history. And so adults and people tolerate 1-inch differences reasonably well. It's only when the difference exceeds about 3/4 of an inch that we start worrying about it. And I often tell people about half the people in the world with a 1-inch leg length difference don't even know they have it. So there isn't a lot of reason to treat these small differences. It's only when they get bigger than about 3/4 of an inch, approaching the inch, that we start worrying. Children actually tolerate the leg length differences better than adults do. And adults do get some back pain and some hip pain if they have to walk long distances with a big difference. But children rarely ever complain about their legs being different and tolerate it quite well. The differences in leg size tend not to cause pain or scoliosis or arthritis. They don't wear the joint out. And they don't need to be treated at a young age. We just treat some of them because of what they can do in the adult life. And so we start doing that at about 3/4 of an inch. That's when we are likely to do something. And these are the things that we can do. We can watch it and do nothing if it's small. We can put a little lift in the shoe, and those can be either inside the shoe or outside the shoe, depending on how big the difference is. In the vascular malformation group, one of the problems with the lift is sometimes the foot is bigger than the other side too, which makes it hard to stick a lift in there. It's hard to get the foot in sometimes, much less to add a lift inside. So we often resort to having to put a lift on the outside, which is more expensive, more inconvenient, makes you wear the same pair of shoes, or you have to take a lot of different pairs of shoes to the place to get the shoe modified. We can slow down the growth in the longer leg, and this is our preferred technique in children. Slow down the longer leg, which in these vascular malformations is also the abnormal leg. And so there's a nice trade-off here. We can slow down that leg, make it not get quite as long as it's going to be, and keep it from getting too much longer than the normal side. We can shorten the long leg. There's ways to do that, and I'll talk about each one of these. In some cases, we can lengthen the short leg. We tend to stay away from this one, and I'll talk about that too. Or we can do an amputation, which is the ultimate way of dealing with a leg length difference, because then one can be fitted with an artificial limb that's the right length, and that often works quite well. These are our sort of rough guidelines for doing those different things. If the difference is less than an inch, we tend to leave it alone or use a little lift. If it's between 1 and 2 inches, we'll try to shorten the longer leg or slow it down. 2 to 5 inch differences are rare, but when they happen, they usually require something much more aggressive, like a lengthening of the short leg. And in the rare cases where we end up with 5 inch differences, which I don't think I've ever seen with a vascular malformation, but I've seen in other conditions, we have to use a combination of these things to get the legs equal. Who should wear a lift? Well, if you have a leg length difference and you're experiencing back pain or leg pain, it's an easy thing to try. It doesn't cost very much. It's not permanent. You can try it, and often it works. It often improves cosmesis if you have a limp, and it's an easy thing to do. If the leg length difference is between 3/4 of an inch and maybe 2 inches, we will talk about trying to slow down the longer leg. And we do that with an operation this is what the operation is called, growth arrest or epiphysiodesis. It's a big long name that you don't really need to remember, but what we do is we go down to that growth plate around the knee, and we actually damage it, hurt it, or stop it. And you can do that by taking a piece of it out. You can do it by drilling a hole in it. You can do it by putting a little staple across it. There are lots of ways to hurt the growth plate. In fact, the majority of my job is to try not to hurt the growth plate. I spend all my life operating around these things and trying to stay away from them, but in these cases where we're dealing with leg length differences, we just simply go in and actually hit the growth plate, and it stops growing. The one at the end of the thigh bone is the biggest growth plate in the body, and we often just talk about it and say it doesn't like to be looked at. If you look at it, it'll stop growing. If you fracture it, or frostbite it, or burn it, or put a screw across it, or a drill across it, it'll stop. And usually that's a bad thing, because most people don't have leg length differences. But in this case, what we'll do is we'll stop it. And then the one on the other side, on the shorter leg, keeps growing. This one doesn't keep growing. And you can get equality if you do it just right and time it just right. That is the trick, and that's why it's hard to do. It's not the surgery that's hard, it's the planning. This is an example of a child with vascular malformation involving this leg, which is bigger, wider, and longer. You can see the heel doesn't come to the ground down here. And the leg length difference measured 2.2 centimeters, about an inch at 6 years and 9 months of age. And then we watched this for a while, and when she got to be 11 years and 9 months of age, 5 years later, the leg length difference had increased to 2.8 centimeters, so that's an inch and a quarter, roughly. And the question became, well, when do you want to slow down this longer leg that appears? This was the patient's left leg. And the correct answer is at the right time, which is, I won't go over it, but we know how much each growth plate in the body grows for different size people and different genders. And so at any point in their life, we can, at least while they're growing, we can tell how much each one of these growth plates is going to grow. And so if you know the patient's age, how mature they are, and how tall they are, what gender they are, you can get some of that information from an x-ray of the hand where there are lots of different growth plates. You can go to this little plot and figure out when to do the operation. And we can get, we're pretty good at it. We usually get within about a 1/4 inch on virtually all these patients that we deal with if we know ahead of time and collect enough data to plot their data online. The kids that are hard are the ones that come in and see us when they're 12 or 13 years of age, about the time when that operation needs to be done. And we don't have any prior knowledge of how old they are, what their growth has been. Makes it a little bit more difficult to predict. But we're still pretty accurate when it comes to getting this right. And this is an example of what we did to this child. We went in surgically, we made a little bitty incision. It's about, I always say it heals and looks like a freckle. And so it's about a 1/8 inch incision, and we actually remove part of the growth plate with these little curved spoon-like devices. And we don't have to remove the whole thing, just a little bit of it. And that causes that growth plate to stop growing. And over the course of time, while they're still growing, the short leg then catches up to the long leg. And that's the most common way we deal with leg length differences. We do it a lot, and it's actually a very, very successful operation. If there's a lot of soft tissue problems and skin problems around the knee, it doesn't seem to matter. We can still make little incisions in that and close the growth plate. Does it keep the leg from getting wider? That's the most common complaint I get, and unfortunately it doesn't. In this case, you can see the difference between the two legs on this MRI scan. This leg has normal fatty layer under the skin. This layer has the real thick hypertrophied fatty layer that we see in KT syndrome. This patient also had some bony involvement. The center of the bone is white, indicating that there's little blood vessels inside the bone, and some of the muscles involved too. And while we can almost always get the legs equal in length, we really struggle with this girth problem. And the worse the girth is, the bigger the problem. So this child, that same child at 14, was left with a leg length difference of 8 millimeters, which is about 1/8 of an inch. She no longer could tell that she had a leg length difference. What if you don't have growth plates? What if you're done growing? Well, if you're an adult, the growth plates are gone, you can't do anything like that. So then you have to do something more aggressive, like take a piece out of the bone. It's what we call a shortening procedure. And this is actually just like creating a fracture, taking a chunk out. Usually we know exactly how much we have to take out because we know how long the legs are, we know how big the difference is. So this is a pretty easy thing to do, but it's a much bigger operation than the one I just described. This is kind of like having a broken thigh bone. And the rehab on it is about 3 months for it to heal. So it's a much bigger operation, it takes longer to recover, and like everything else, the complications and the risks are greater with this type of thing than others. We really do fix it just like we fix adults with broken thigh bones, broken femurs. Big rod down the middle. This is an example of an adult now with a leg length difference that's 3.9 centimeters. That's just under 2 inches. And it was bothersome enough at this point that she wanted to be equal. You can see how much longer the femur is on this side than this side. And so we went in and actually took the chunk out. You can see there's the piece of it. We did this actually without an incision on the thigh. So we put a little saw down inside the bone and then cut the bone, push the pieces out. The femur in the pig is what's the hand bone. It looks like a napkin ring. And so what we do is we go down inside the bone and cut the bone from inside and then split it, push the pieces out, collapse the bone and put a rod down in that space. And then it heals just like a fracture, but it takes about 3 months to do that. A lot of people don't really want us to slow down their longer leg. And they would much rather be taller than a little shorter. And so one of the common questions I get is this one: why can't you just make my short leg as long as my long leg so I will be taller? I want to play basketball, I want to play volleyball, and I don't really want to be a little shorter. I want to be taller. And the answer is, well, we can, but it's such a big deal that we'd rather not. And you would rather not. And so this is an example of what we can do, and we use it for a lot of conditions, but not very often for vascular malformations because it's such a big deal. And this is an example of a femur that we're going to lengthen. So we put pins through the skin above and below where we cut the bone. So we create a fracture here with a saw. And then this device, which sits out on the outside of the body, has a little crank on it, and every day we turn it and we lengthen, we pull those two pieces apart 1 millimeter a day. So if you had a 4 centimeter difference, which would be almost 2 inches, in 40 days you could get that much length back. 40 days, a month and a half. And then it takes, then you have a gap. Now you have the two pieces apart, but there's a gap between them. Well, if you pull at 1 millimeter a day, it actually starts healing, and it'll fill in that gap. But that takes twice as long as it took to get there. 40 days to get there, 80 more days, that's 120 days. So now you're talking months. So you have to wear this thing, go to school with this thing, go to work with this, use crutches, it hurts. And the complication rate is pretty high, especially if this patient has a vascular malformation. You put this through that skin that Dr. Tollefson was showing you earlier that bleeds and gets infected. And so it's an undesirable thing to do in most patients with leg length differences of under 2 inches. We won't even really think about it. And so it works pretty good. This is an example of a tibia that we did. This girl did not have a vascular malformation, but you can see here we pulled the two ends apart like pulling that candy apart, like taffy. And it kind of stretches and fills the gap in, and then eventually you can take the fixator off. But most everybody wants the fixator off about the first day it's on. And so we don't do this too often. You can do it in the thigh and the calf at the same time. And there are some conditions where it's the only thing we can do, but we try not to do this too often because most people don't like it. Can we do anything about the size and girth of the leg? Well, we don't have a good method to slow the growth of the soft tissues, and you'll hear a little bit more about that later, but compression and removing the tissue is about the only thing I can do. And since I'm a surgeon, the removal part is what I'll talk about. There are some attempts to take out tissue, and we tend to refer them as debulking procedures. Ultrasonic liposuction has been tried, but it doesn't work very well because this fat isn't the nice sort of soft, squishy fat that the liposuction plastic surgeons like to deal with. It doesn't suck very well, it doesn't cut very well. It's more like, it has a real gritty substance to it, and it doesn't like to. And a lot of times it bleeds, so you can find yourself trying to suck out all of the patient's blood if you try to get too aggressive with some of these. Surgical excision can be done. There are some places in the body where we can actually take out these things, especially if they're localized. This boy had a vascular malformation right here, which is pretty small, and it was just in the way, and he didn't like the way it felt or looked. And so we could go in and just take it out. This one has sort of a good characteristic to it. It's more fatty and doesn't have a lot of big blood vessels in it. But in those limited cases, it can work pretty well. In some cases, however, we just simply can't do this, and attempts to do it are just not successful. Amputation can be done. It's a single surgery. It improves function. It often takes care of all those recurrent infections that occur in the part that is removed. Bleeding can be a problem. And in some cases, it's really the only choice we have. In a child like this, with a leg that is heavier than the rest of the child, where it bleeds and is just essentially an anchor that has to be dragged around, sometimes the best thing we can do is remove it. In every amputation I've done, it tends to leave part that is still involved, that still gives us troubles. And those troubles can be just the bulk of the remaining limb. It can be sensitivity, skin breakdown. It can be deep venous thromboses, blood clots that form in the residual part. I don't think I've done a single amputation, except maybe one, and I'll show it to you, where everything turned out really well. But it is a good solution for a lot of people. This is one of the amputations that worked out really well. This child had a vascular malformation that made the toes longer, and we ended up amputating part of the foot, and that one worked out really well. We can stop growth plates in the foot like we can in the legs, but there's 19 growth plates in the leg or in the foot, and it's just too many to attack. This was an amputation of a large part that when we took it off, the child could wear shoes again. The shoes could be the same size, and the foot ended up working pretty well. This child kept getting sent home from school because he had these, what Dr. Tollefson refers to as blebs that would bleed, and he would get to school, the sock would get saturated, it would start leaving little puddles of blood around the classroom, which in today's age isn't really acceptable, so he would get sent home, and after missing about a quarter of a year of school, they came to see us, and at this point we didn't think there was anything we could do with the laser, because it was just too dense, and when we would laser it, it would remove too much of the skin, basically. So we ended up doing an amputation of both the second toe and the end of the first toe. And this allowed him to go back to school to wear a shoe and not come home with bloody socks every day. The other thing I'll talk about, which is completely different than the leg length differences, is the intra-articular manifestations of this condition. And we see kids who get these vascular malformations inside their knee joint or inside their hip joint or their ankle joint. And it tends to be a really bad thing to happen. When the vascular malformation gets inside the knee, it tends to destroy the white shiny cartilage that's in the knee and eventually wear the knee out. It doesn't take long for this to happen. This was a really young child that we identified early because there was some swelling in the knee. And it turns out this is the vascular malformation, this sort of collection of dark-looking things. Those are veins, actually, little veins. We removed this, and now you can see the rest of the knee looks pristine. That's what a knee is supposed to look like in a young child. I think this child was 4. And this child has done really well, but we only learned this by finding out what happened in other cases like this one, where the vascular malformation completely involved the knee joint and actually destroyed or ate through the white shiny cartilage on the bottom of the kneecap and the end of the thigh bone. And once we lose cartilage, we don't grow it back. So it's one of those tissues in the body like brain cells. And once you lose it, you don't get it back. And unlike bone or skin, the cartilage is unforgiving, and once it's gone, it's gone. This was another child where we got to it pretty late, and a lot of the knee joint has been destroyed. There are big holes in the cartilage. This is an arthritic knee. That's what lack of cartilage is. It's arthritis. And you can see that it doesn't do well. So now we go after these pretty quickly when we see them. We used to do a similar thing for rheumatoid arthritis, and it really didn't work, but for the vascular malformations, it seems to really help. And then there's this small group of patients who have the bony involvement that is visible on x-rays, where it looks like Swiss cheese, and it is, in a sense, a form of holes in the bone. And these things will break, they hurt, they're hard to deal with. We don't have a perfect solution for it, but we try to keep it from breaking. Sometimes we'll put rods in there to keep things from breaking and moving. In summary, for length, we'll will do these things that we talked about, and they are predictable, they're pretty good, we can deal with the length in a good way. We have a lot more trouble dealing with the girth of the foot and the leg, but there are some things that can be done. And I hope I've not covered too much for you in too short a time. Thanks.
Can we have any questions for Dr. Shaugnessy?
For patients who are older and have the knee involvement,
Yeah.
what are the options there where there is some damage as you showed? What do you do there?
Yeah, ultimately, a knee replacement can be done. Artificial knee joint can be put in. It's an operation that we do for a lot of people with arthritic knees for lots of different reasons. The older a person is, the better an operation it is. And for the 50, 60, and 70-year-old population, it's probably the best thing we have. It's probably the best operation that orthopedic surgeons can do for anybody. The success rate is really high and the failure rate is really low. So that's a great thing for the elderly. It becomes less good as the age gets younger because younger people wear out artificial joints. And so if you're 20, the chance of you wearing that joint out by the time you're 30 is pretty good. And then the second and third knee replacements aren't as successful. There are some other things that can be done to try to salvage a knee that is arthritic. Removing the vascular malformation is probably the best thing, but once the damage is done to the joint, it's hard to recover from that. There are operations that we used to do in the era before we had knee replacements, a knee fusion, where you can actually make the knee stiff, get the thigh bone to heal to the shin bone, but it comes with a big cost, and that is that you can't bend your knee getting into cars and things. But it removes pain, and it actually works pretty well for a young person who wants to be really active.
You talked about with the amputation in the leg area that complications were common. When you amputate toes, similar rates of complication or better?
The toes actually do much better and actually any amputation does better if there's a limited involvement by the vascular malformation. The ones that are hardest are the ones that I showed where the vascular malformation extends from, say, the trunk all the way to the toes. It's hard to do that one well and to not have difficulty with it. But if you have just an isolated second, third toe problem, those actually do really well. You can live without two of your toes and two of the rays of your foot and still have a pretty normal life. And even the absence of the big toe is a negligible problem. You can be completely functional without your big toe. So those work really well. It's the ones where we have to leave part of the vascular malformation or half the vascular malformation behind when we do an amputation where we run into trouble.
And so you would usually, if there's a big problem with the toe, you would usually amputate as opposed to shorten, right?
Yeah.
Bother to shorten.
Yeah, it's hard to shorten the toes. It can be done, and if we see the kids really early in life, 2, 3, 4, 5 years of age, and we know we're going to run into trouble, we can close those growth plates down. And what I usually do is I wait till the affected toe on the child looks to be about as big as the toe on the parent, and then I stop the growth. The trouble is it only stops the length. It doesn't help you with the girth. And often that's the big problem with shoe wear is girth.
What's the best way to identify if the knee joint is involved?
It usually swells up, and it usually gets puffy and swollen. And in the cases that we've seen here, they usually start losing motion. And the motion they first lose is full extension. They can't get it fully straight. So you see the child walking around with a slightly bent knee that looks puffy and swollen. And I always tell people, if you can't see the contours of your kneecap, that means there's something going on in your knee. Now it could be, it doesn't have to be a vascular malformation, but that's one of the reasons that this can happen. And it's usually warm and to the touch and bigger than the other side. If we see that, then we're going to almost always get an MRI scan. That usually tells the story. And if we see it in a young child, especially 2, 3, 4, 5, 6, we'll go in and remove it.
What's the difference between taking out part of the great growth plate and using the drilling procedures, one just less invasive than the other?
Yeah, that's really all there is to it. The hard part is finding it. You can't see it from the outside, and it's actually pretty hard to feel it from outside the body. So we have to use some X-ray device in the OR. But the reason I do it is because the cosmetic result's much better if I don't have to make a big incision. And in most of the patients, they don't really want big incisions on the leg that already has some abnormalities on it. Some of the guys don't care. Some of them want a big incision. But usually it's a lot easier just to do it through the little poke holes.
I've heard, some talk about potential bone density implications of KT. Is that something?
Yeah, bone density is really a tough problem with KT. And it's hard to quantitate because bone density is related to age. So as we get, as we age, our bone density changes. Little kids have low density. 30-year-olds have the greatest density. And after that, it's all downhill. We lose it every year of our life. If you don't walk on a leg for any reason, your bone density in that leg gets less. And it's called disuse osteoporosis. And every time we put a child in with a broken leg in a cast, the density in that leg drops off. By the time we take the cast off, it might only be 20, 30% less than normal. It recovers, of course, once the child starts walking on it. But the KT population has variable degrees of pain. And if your leg hurts, you don't walk on it. If it hurts a lot, you really don't walk on it, and your density drops more than if you do. So a lot of the osteoporosis, the low bone density we see in the KT population is because it hurts. Some of it is because the bone is replaced by blood vessels. That's the Swiss cheese thing that lowers the bone density. And some of it is just age. So all these factors are compounding each other. But in general, if you look at the unaffected parts of the body in KT, I don't think it's affected. But if you look at the affected parts, the leg that is affected by KT, you'll find that it's got a lower bone density probably than the other parts of the body if it hurts and they don't use it. Okay, thank you very much.